All right. So I'll be talking about secondary headaches, which should not be missed. We know that International Headache Society has classified headaches as primary headaches and secondary headaches, and there are at least 7 or 8 types of secondary headaches which have been described by the International Headache Society. And we all know that primary headaches is probably the most common disorder. More than 90% of the headaches are primary headaches. But the secondary headaches are important for neurologists because there are certain disorders which require special treatment. So let me start with the question. You don't have to answer. There is no Slido into this, but there's a question which I'm asked that which of the following is a secondary headache? Benign paroxysmal torticollis, hypnic headache, new daily persistent headache, and medication overuse headache. And the answer to this question is, of course, medication overuse headache, which is a part of 8.2. Rest all are primary headaches. Benign paroxysmal torticollis actually is a part of migraine spectrum, while rest are the other primary headache disorders. So we know that secondary headaches are not common disorders. This was a large study of about 3,800 patients, which was seen in a headache clinic, which were running for 24 hours. They had 6.4% of their patients which were secondary, and the commonest causes were sinusitis, post-traumatic headaches, spinal leaks, and various vascular disorders. So we know that these disorders of secondary headaches are not common, and we have to remember this Snoop, which will come again and again from our college days. We are talking to this. So we have to remember this red herrings as far as headaches are concerned. We have to remember this mnemonic, which is very simple, Snoop. So systemic symptoms like fever, weight loss, or secondary risk factors like hypertension, HIV or systemic malignancies. If the patient has got neurological symptoms or signs like impaired consciousness, focal deficits or confusion, we know that you're looking at something which is serious. Or if the onset is sudden, abrupt or split second, like a thunderclap headache, then we know that the headaches may be severe headaches, or the headaches are dangerous headaches. Headaches which start in old people, we know that these are dangerous headaches. And if the patient has got headache, and if the headache changes its nature, or if the patient gets new onset headache, which is very severe, then one has to think of certain things which are very serious. So one has to remember this mnemonic called Snoop, which is very easy to remember. And then the second headaches have been classified in various types. Again, I'm not going in detail. All of us have read this International Headache Society classification many times. Secondary headaches are usually diagnosed on the basis of investigations like imaging, CSF, and certain lab parameters. And then we can get these disorders like empyema. This patient actually had Salmonella typhi empyema, and then various types of meningitis. This girl has an carcinomatous meningitis, but then it was diagnosed on the basis of imaging and CSF. The more dangerous are the headaches where the routine imaging may be normal or near normal and the disease is treatable. So these are the headaches which are dangerous. You know, we can get exotic images where the diagnosis can be easily made on the basis of imaging or on the basis of lumbar puncture findings. But if the imaging is normal and if the disease requires different treatment, then these are the dangerous headaches. So I'll be talking about these secondary headaches which we shouldn't be missing even if the imaging is normal. And as usual, I'll run a case-based show. So I'll start with a case. This is a 61-year-old male who presented with 3 weeks history of headache. The headache was bilateral, daily, throbbing. There was no nausea, vomiting. There was no medical illness in this patient. His nervous system examination normal. There was no papilledema, no neck stiffness, nothing. So essentially 3 weeks headaches with normal imaging. But you look at the general examination of the patient and you see this tortuous vessels in this man. So this patient was investigated. Of course, we all know that this is a giant cell arteritis. ESR was high, C-reactive protein was high. He was treated with steroids and he started improving within 3 weeks. And this is his follow-up after 1 month, where you can see that the vessels tortuosity has severely reduced. Of course, this kind of severely tortuous vessels we would rarely get in our clinical examination, but one has to look at the vessels and one has to try and palpate these vessels. So giant cell arteritis is common in old people. One has to suspect in all people where the headache starts after the age of 50. We know that the headache can be unilateral or bilateral, throbbing, episodic or continuous. So the headache quality cannot differentiate between various types of headaches as far as giant cell arteritis is concerned. It may be associated with ischemia of the optic nerve. We know that AION, jaw claudication and polymyalgia rheumatica. We all know these features, right? The common arteries are involved. The commonest artery superficial temporal, but actually the dangerous arteries are the ophthalmic arteries, the posterior ciliary arteries, and sometimes the intracranial arteries like the carotid arteries and the vertebral arteries, which can produce strokes or ischemia of the optic nerve. So the phenomenon is usually diagnosed with the help of superficial temporal artery, but the other arteries are more important because they can produce more devastating features. they have inflammatory markers with which the diagnosis is done. Thrombocytosis is there, one more feature in this patient. So if you do hemogram, the platelet counts actually can be high in these people. Histological proof is gold standard, but we know that it is difficult to get it because doing a biopsy may be difficult. Sometimes the lesion is skip lesion. So the area where you have done biopsy, the lesion may not be present, and you give steroids, the inflammation dissolves rapidly. So, after starting steroids, the biopsy may fail. Some people also do USG of the temporal artery, Doppler of the temporal artery for diagnosis. Even people are doing PET scan sometimes in this diagnosis. Steroids should be started early, not for the prevention of, for the treatment of stroke, but to prevent AION. And if the patient has developed AION in one eye, the chances that he or she will develop AION in the other eye within first week is very high. So you have to give them steroids early. There are diagnostic criteria where one can, I don't go in detail of the criteria, but you see the ESR value should be above 50 for diagnosis. So ESR like 23, 24, which we see fairly often in patients, which is not important. It should be above 50 for diagnosis of giant cell arteritis. And as far as treatment is concerned, the drug of choice is steroids. The dose is 0.7 milligram per kilogram. If the disease is more severe, like patient has got aneurysm or ischemic complication, then the dose is 1 milligram per kilogram. The steroid sparing agents used here are not azathioprine like we use in other disorders like polymyositis or myasthenia. The agent that is used is either methotrexate or tocilizumab, the drug which has become famous in the COVID era at present. And if there are relapses, then you can switch the patient either to methotrexate or to tocilizumab, or maybe between these two, depending on the patient. And of course, if the patient has got steroid related problems, he's not tolerating steroids, then one can use even tocilizumab as a first line drug in some of these patients with low dose of glucocorticoids. And then these are other drugs which are under evaluation as far as treatment is concerned. Of course, many of the neurologists won't be aware of these drugs, but if you treat patients with steroids and then follow them with methotrexate, and if the patient is not responding, make sure that you consult your rheumatology friends for the diagnosis and treatment of giant cell arteritis. Going to the next case. This was a 17-year-old girl appearing for her 10th exam, and one can easily make out the case. 1 week history of bilateral throbbing headache, increasing severity associated with vomiting, no visual symptoms, no past medical illness. The girl is obese girl, has bilateral papilloedema, and the diagnosis is very simple for neurologists. We all know that imaging will be normal in these people. There may be sometimes some stenosis of the venous sinuses, some of these patients, and of course the opening pressure of the CSF will be high in these people with CSF coming nearly blank. So and the perimetry sometimes may show some abnormalities. We know that this is a syndrome of intracranial hypertension, IIH. This girl was admitted in the hospital. We drained about 30 cc of CSF. She was given low salt diet and acetazolamide was started. But the things did not go well. 2 days later, she developed sudden reduction in the vision in one eye, and she almost became blind. And one can see that in perimetry, the vision has rapidly, dramatically worsened in this girl. So we have to do an so what next do we do? Do we do an emergency TP shunt in this girl? Do we repeat CSF and drain the CSF? Do we give her a shot of steroids so that the vision will not worsen? Or do we do an urgent surgery with an ophthalmologist, which is called as optic no fenestration surgery? So this is a question. Of course, I don't have a question, but think about this. What do we do as an emergency treatment of idiopathic intracranial hypertension? So we know that the disease is not benign disease. The name benign has been removed. Of course, one has to remember the mimics, which can present like IIH. So these are the syndromes where patient can have raised tension, like chronic meningitis, where patient may not have hydrocephalus, and the CSF abnormalities may be plus minus. Multiple cysticerca in age-old age, when plain CT scan were done, if there are multiple cysticerca, it may just show some cerebral edema without any obvious cysticerca. Of course, with the MRI, the diagnosis of cysticerca has become much easy. Chronic venous sinus thrombosis, especially the lateral sinus thrombosis, can present with a syndrome of raised intracranial pressure. Dural AV fistula, again, we know is an important mimicker of idiopathic intracranial hypertension. So one has to remember about this. And in disorders where the CSF pressure is high, like GBS or spinal block, sometimes one can get raised proteins in the CSF, and that can cause papilloedema, and sometimes headache may be present. So it may mimic IIH in some of these patients. So the mimickers are important for neurologists to know. The headache of idiopathic intracranial hypertension may mimic migraine or tension type headache. There are no specific headache features. This has come from the large idiopathic intracranial hypertension treatment trial, where the commonest headache was like migraine like headache. So if you just go on the history of headache, you can't diagnose IIH. And the headache severity does not match with the CSF opening pressure. So it doesn't mean that someone who has to have severe headache to have severe, very high intracranial pressure. So headache severity may not match with this CSF opening pressure. And then there are medications which are associated with IIH. We know that antibiotics like tetracycline, vitamins like vitamin A certain hormones like human growth factor, even thyroid hormones in children, anabolic steroids, and withdrawal from chronic steroid therapy is also known to cause rebound IH-like syndrome. Lithium can sometimes cause IH-like syndrome, and certain medical conditions like endocrine condition, like sleep apnea, anemia, renal failure, and these disorders like Turner syndrome and Down syndrome can sometimes present with syndrome like idiopathic intracranial hypertension as well. Treatment option, the most important option of course is weight loss, but it is going to take time. Weight loss doesn't act immediately, so weight loss is the mainstay of the therapy. Of course, on the long-term basis, drugs that are used are acetazolamide. In the trial, the only trial which is available with idiopathic intracranial hypertension, where they use acetazolamide, where it was shown to have modest effect. Other drugs which can be used are other diuretics. Sometimes people have also used topiramate, which is again a drug which acts on carbonic anhydrase. Steroids have beneficial in certain patients, but again there is a question about steroid and it's a controversy. I'm not going in controversy of steroids. And therapeutic lumbar therapeutic CSF drainage has been done. How much CSF has to be drained is always a question, because we know that if you drain too much, patient gets this post lumbar puncture headache or post LP headache. So there is one formula which is being used, and it's a good formula. I use it in my practice. So I measure the opening pressure and negate 25 from it. So if the opening pressure is 55 minus 25, it comes to 30. 2/3 of that is drained, so that we drain 20 cc in this patient. And if you use this formula, 2/3 of opening pressure minus 25, you can reduce the number of post lumbar puncture headaches in these patients. Again, this is only one study which was been published some 2 years back. Various surgeries have been done as far as treatment of idiopathic intracranial hypertension is concerned. Optic nerve fenestration surgeries, then various diversion procedures like lumboperitoneal shunt or ventriculoperitoneal shunt have been done. Again, surgeons are not willing to put a shunt in the ventricles which are chinked, so they like to do lumboperitoneal shunt. The problem with lumboperitoneal shunt, we know that there are no walls in these, so maybe drainage, there may be over drainage in some of these patients. Bariatric surgeries have been suggested as a procedure for weight loss, not directly affecting idiopathic intracranial hypertension, but it can be done in some patients. And this venous stenting is a controversial entity, and I don't want to go in the controversy of this. Talking about dural AV fistula, again, it's a common condition, and especially with the MRI techniques, we are able to diagnose it more often. We must know, and this is just one slide about dural AV fistula. The neurology of dural AV fistula: if the dural AV fistula is intracranial, then the abnormalities are, they may present with IH-like syndrome. Some of them may present with subacute encephalopathy with white matter lesions, and sometimes they can bleed, which is the rarest of all three. And patient, if there is a spinal dural AV fistula, it typically presents as a subacute progressive myelopathy in old man, where the myelopathy involves thoracic area, and rarely it can produce spinal SH. So dural AV fistula is important disease to know, especially as a mimicker of all these disorders. Talking about another case, this is 35-year-old female. She had headache which started 15 days ago. The headache started gradually. It was bilateral, occipital, moderate to severe, more in daytime, less at night, occasionally associated with nausea, no fever, no past history of headaches. This lady had rheumatoid arthritis, and she was on HCQS, a drug that is nowadays being completely in limelight. She was seen earlier and investigated, where she had undergone this MRI, where this was a plain MRI of this lady. One can see that there are some bilateral CSF collections here. So bilateral hygromas were there. She was investigated. The ESR was 44, lab was normal, rheumatoid factor was positive. The CSF was done in this lady, where the proteins was 86, glucose was 67, and she had 25 cells. This was the CSF with which she came to us. So she was given various analgesics, tramadol, amitriptyline, antibiotics, and there was no relief. The CSF had cells, so they were suspecting that there may be even a chance that she may be having a meningitis. So the question is, what next? Do we give anti-cox treatment? Do we do a contrast MRI? Do we do some angio? Or do we do some special tests on the CSF in this lady? The answer, of course, we all as a neurologist know, we have to do a contrast MRI, and this was a contrast MRI in this lady, and one can see that there is a pachymeningeal enhancement which is diffuse in this lady. And the diagnosis we know is this is a syndrome of spontaneous intracranial hypotension, SIH. She was treated with bed rest, IV fluids, analgesics, and then of course we also did a gadolinium MRI of the spine of this lady, where intrathecal gadolinium was given, and you can see that there are collections which are coming out in this area, and there is also collection coming here. So she definitely had evidence of spinal leak. And then she was given epidural blood patch, bed rest, analgesics, hydration, and the headache subsided significantly. And we repeated her MRI after 1 month. The hygromas have nearly disappeared, and there are very subtle hygromas, and you can see that even the enhancement also is significantly less in this lady. So the syndrome of spontaneous intracranial hypotension, it is actually a misnomer, like the press. It is not spontaneous because many times it comes after trauma or it comes after patient who have additional connective tissue disorders. So 2/3 patient have connective tissue disorders, 1/3 may have trauma. Second thing is eye. It is not intracranial. The disease we know actually in the spine. The cause is usually spinal. So they have a spinal leak. So the cause is not intracranial, it is spinal. And then the third is hypotension. Actually, if you measure the CSF pressure, only 50% will have low CSF pressure, by definition less than 6 centimeters of CSF. So this is a misnomer actually. It is not spontaneous, it is not intracranial, it is not hypotension. It is a syndrome which is seen in about 5 in 1 lakh. Around 40 years is the peak, more common in female. And as I said, the cause is spinal leak. MRI abnormality in these patients are many. But remember that MRI may be normal in 25% of the patient. There may be diffuse brain swelling. There may be subdural collections. There can be subdural hematomas sometimes. There is a sagging of the brainstem, and there are various signs described like droopy penis sign. There is increased fluid around the optic now, and then the rounding of the cross section of the venous sinuses. And if you give contrast, of course, we know that there is venous sinus engorgement and there is pachymeningeal enhancement, and pituitary also can be enlarged and may enhance if you give contrast in these patients. One has to find leak in these patients. So not just doing MRI of this brain is important. We have to do imaging of the spine. And the best way actually is to do double myelogram of this patient. So you give some IV fluids, you remove CSF, and then you put both CT contrast dye as well as MR contrast dye at one go, and then image the patient. Initially CT is done. This will find out the fast or the high flow leaks, and then you could do an MR, and MR can find out slow or low flow leaks. There are now newer techniques where you can do MR myelogram in this patient without giving intrathecal gadolinium, but still gadolinium is considered as gold standard. Remember that gadolinium has not been approved as it, so it's an off-label indication of gadolinium in these patients. So one has to not stop at only doing MRI of the brain in this patient. One has to image for the leak of also in these patients. And then there are diagnostic criteria where you see that the most important diagnostic criteria is finding out leak. If you have leak, then the diagnosis is done. You don't have to do any other test. If there is no leak, then one has to look at the cranial MRI changes. Then one has to measure the opening pressure, which we usually won't do, and then see if there is improvement with the epidural blood patch or if there are diverticula in these patients. And if both are absent, then one has to look at the pressure. One has to see if there are meningeal symptoms in the spine in this patient for leak, and if there is improvement after epidural blood patch. So this is a diagnostic criteria. The most important thing is that one has to try and find out leak in these patients. The treatment would include conservative therapies where bed rest, elevate the foot end of the patient, giving the drugs like adenosine receptors, blockers like caffeine, theophylline in some of these patients. One can use abdominal binders, analgesics, steroids sometimes in some patients. Sometimes occipital nerve blocks are given because the brain is predominantly occipital in these patients. Hydration and time is usually therapy. Many times conservative therapy helps, but there are patients where conservative therapy fails, where one has to go for further treatment, like either giving an epidural blood patch or the suturing or closure of the leak, which is done by neurosurgeon. The commonest therapy that is used is epidural blood patch. We know that epidural blood patch is simple therapy. Typically, before epidural blood patch in our center, we always do blood culture of the patient to make that there is no infection in the blood, and then we give around 30 cc blood patch. The area where the blood patch is given, some people say it has to be given at the level of leak, but you don't have to give at the level of leak. You can give it even at the lower level, because when you give epidural blood, it causes tamponade and it causes the leak temporarily. And of course, then it will cause some chemical reaction causing fibrosis and inflammation, and the leak can be blocked for some time. After the leak, one has to remember what are the things which has to be done. Patient has to remain in bed for 24 to 48 hours. 48 hours. Don't start his don't give NSAIDs or don't give antiplatelet agents or anticoagulation. If you have to give anticoagulation, one can start enoxaparin in some of these patients. And first 4 weeks, patient should not lift more than 10 pounds of weight. You should avoid straining during bowel, so you can use bowel softeners in these patients. And patient should not bend to lift objects. If you have to bend down, use your knees rather than bending at your waist. And then, of course, avoid activities where there will be twisting of the trunk. So one has to avoid these things. These are important things after epidural blood patch. So spontaneous intracranial hypotension is a fairly common condition. One has to remember this, and because the treatment options are totally different compared to our standard treatment of other headaches. Talking about another case, this is 65-year-old female. She had presented with headache since 3 months. Headache was predominantly occipital. It was radiating to the temporal as well as the neck area. It used to last for less than 5 minutes, and it was triggered by laughing, coughing, and sneezing, occasionally bending forward. This is what the headache was. This is what was causing the headache. So we know from the history, the headache which comes from laughing, coughing, and sneezing, we know the diagnosis. It is usually Chiari malformation. So Chiari malformation can have several types of headache. They can have short-lasting headache, which come with coughing, sneezing, and Valsalva maneuver. They last for a short period. Sometimes the headache can be longer lasting, which is not triggered by Valsalva. They can last for 3 hours to several days, and there can be a continuous headaches in these patients. So they can get 3 types of headaches, and they may be associated with neck pain, arm pain, dizziness, and of course we know there are a large number of neurological signs which can come with Chiari. But these are the types of headaches that would come with Chiari malformation. This was a short case. Next case is a 80-year-old male. He had underwent retinal detachment surgery about 1 week ago. Then he started getting pain in the left eye and around the left eye. The pain went in the frontal area, temporal area, even in the occipital area. It was daily, continuous and throbbing pain. There was no fever, no redness of the eye. Patient was diabetic. He was only on diet control and had hypertension. He was seen elsewhere. He was treated with various analgesics and antibiotics. Ophthalmologist opinion was taken and he said everything is fine from my end. MRI of the brain was done, which was normal. Still, he did not have any relief. So when he came to us, he had bilateral mild deafness, no discharge. There was tenderness over the left temporal bone. He had a left 6 nerve palsy. There was no other deficit and there was no neck stiffness. So this was what this patient had. He had 6 nerve palsy. He had some tenderness on the temporal bone and then general examination was normal. So what do we do in this man? Do we do ESR and CRP because he's above 80? Do we refer to another ophthalmologist to see if there is increased pressure? Do we do lumbar puncture or do we repeat the MRI in this patient? He had already undergone a contrast MRI, which was normal. What was done was we did his MRI, which was repeated. The MRI was not repeated for brain, but we looked at the brain skull below the brain at the skull base. And you see there are large shaggy inflammatory areas at the skull base of this patient. So this patient had a phenomenon of skull base osteomyelitis. Skull base osteomyelitis is a serious life-threatening condition common in elderly diabetic patients or even in immunocompromised patients. Typically, it comes as a complication of otitis externa, where the bones of the external auditory canal are involved, and then it involves the bones, and then the cranial nerves are involved. It is usually caused because of Pseudomonas. It's a difficult disease to treat, but it's a well-known entity. There's another form of, usually it is associated with headache. The headache can be unilateral or bilateral, throbbing, progressive, and there are associated symptoms like deafness. Usually, otitis externa does not produce any discharge. The discharge usually seen in otitis media. And they may have additional cranial nerve involvement. The commonest cranial nerve is 7. There may be 6, or the lower cranial nerves also can come later in this patient. There is another disease which is called as atypical or a central skull base osteomyelitis, which starts from the sphenoid and the occipital bone. So it is a central disease which starts from the sphenoid. Typically, the disease is centered around clivus. It presents with headache and varieties of cranial neuropathies. So commonest is 6 and the lower cranial nerves in here. So typically, this can mimic sometimes malignancies. So where histological diagnosis may be important in some of these patients. So to differentiate between the typical as well as the central skull base osteomyelitis, diabetes is more common in typical skull base osteomyelitis. It starts in the external ear, but here it starts near the sphenoid sinus. Primary bone involved here is temporal bone here, while in central skull base osteomyelitis is clivus which is involved. The cranial nerve involved here are 7th, 8th, where the 6th is commonest here. And the organism may not be Pseudomonas in the central skull base osteomyelitis. Sometimes fungi and TB can also cause this disease. The MRI abnormalities, I am not going in detail, but one has to look at the clivus in this patient. Clivus on T1 usually is always hyper intense. If there is some hypointensity in clivus anywhere, or if the complete clivus is hypointense, then one has to suspect central skull base osteomyelitis. In this patient, you see that this only the half of the area is hyperintense, the rest is iso or hypo. So that's the typical feature of central skull base osteomyelitis. So this is in our patient. ESR is raised in this patient. It can be used to monitor the disease activity. And if the ear discharge is there, one can send the culture, but many times. The treatment options are to give antibiotics. Antibiotics are to be given for a long duration. The duration is between 1 month to 6 months. Initially, IV antibiotics are given. One can use antibiotics. One should use antibiotics which penetrate the bone, and the drug of choice is actually quinolones like ciprofloxacin as a drug of choice which is being used. Surgical debridement can be done whenever there is disease which can be removed by ENT or neurosurgeon, and there is some role of hyperbaric oxygen in some of these patients. So this is an important entity to remember because the treatment option is different. One has to use antibiotics for a very long period, like the antibiotic which penetrate bones like quinolones, and the drug of choice is usually ciprofloxacin. Going to one more case. I will just go quickly in this patient. This was a patient who was 40-year-old man who presented with sudden onset of headache while taking hot water bath. He was taking hot water bath. He had a severe pain in the vertex and the occipital region associated with nausea, which lasted for 1 hour, and then it improved. He came to the hospital. His CT scan was normal, nothing. Next day again, while taking hot water bath, he had a similar pain. So he had a severe pain while taking hot water bath, which was done twice. So we did his MR angio, which was normal. MRI was normal, as well as the angio was normal. In the hospital, he had nothing. The CSF showed no abnormalities except 15 cells and proteins of 83. So the question is, what do we do? What is the diagnosis in this man? So the angio was repeated in this man, and I'll just show about this angio. I'm just running this case fast. So this patient had a thunderclap headache. We know that thunderclap headache is a headache which comes severely, suddenly. So the diagnosis of thunderclap headache is done when the headache comes to the peak within 1 minute. It lasts for between 1 hour to 10 days. It usually will not come again and again. Very rarely the thunderclap headache would come again and again, and they will have nothing else. So primary thunderclap headache will not have no other abnormalities. And sometimes in the primary imaging as well as CSF should be normal. So the causes of secondary thunderclap headache, something which looks like thunderclap headache which is secondary, includes large number of disorders which are all related to vessels. So subarachnoid hemorrhage, sentinel hemorrhage, intercerebral hemorrhage, venous sinus thrombosis, dissection, CNS angiitis, RCVS, all these disorders are related to the vessels. So one has to remember that if you are looking at a patient of thunderclap headache, don't just look at his brain, but also one should look at his vessels. That is the message. So this is our patient where the first angio was done. I won't beat around the bush. He had RCVS. So you can see that some of the vessels here, the vessel is being occluded, which was not seen, which was seen earlier. Here, the vessel is showing spasm, as well as there is some amount of spasm which is coming here. So this patient had RCVS. His earlier angio was normal, and when we repeated the angio after 2 weeks, the second angio was abnormal, and there was RCVS in this man. So this patient had syndrome of RCVS. There was a discussion of RCVS about few days ago in one of this fine evening programs. So I won't go in detail of it. There are a large number of other names which were given, and it was Anish Singhal who really coined this term RCVS. The clinical features include recurrent thunderclap headache. There may be focal deficits which can come later. Some of these patients may rarely oppress. Seizures may be there in some of these patients. And drugs, serotonergic and sympathomimetic drugs, as well as pregnancy may be predisposing factor in 60% of the patient. There are diagnostic criteria where one has to do angio, and we have to demonstrate that the vasoconstriction improves after 12 weeks, and there is no other evidence of SH, etc. The treatment wise, there are no large studies, unfortunately, in this entity. The drugs that are used are calcium channel blockers like nimodipine or nifedipine or even verapamil have been used. Short course of steroids were used in earlier reports. Nowadays, no one uses steroids, and one has to stop the offending drugs in these patients. So in thunderclap headache, one has to remember that one has to image both brain as well as vessels when you are thinking of thunderclap headache. And if you have a patient of recurrent thunderclap headache, suspect RCVS. Talking about couple of other secondary headaches which are important for neurologists. One is headache which will come with dissection. 70% of the dissection patient may have headache. Headache is usually ipsilateral to the side of dissection. And if it is carotid artery dissection, then the headache is usually anterior headache. Vertebral artery pain will be predominantly occipital. The quality is usually steady in a large number of patients and pulsatile in few of these patients. There may be associated neck pain in carotid is anterolateral, while it is posterior in vertebral artery, and it may be a presenting feature in 50% of the patient of carotid artery dissection. So remember that dissection may be an important cause for secondary headache, while 1/3 of the patient of vertebral artery may have dissection, and there may be eye and face pain in 10% of the patients of carotid artery stenosis. So dissection is an important condition which is in a cause of secondary headache. Talking about the last headache, the post-traumatic headache, it's a diagnosis which comes as a mixed bag. We don't know how to diagnose post-traumatic headache. The definition says that the headache should start within 7 days of injury or within 7 days of regaining consciousness from a head injury. It can be acute, which lasts for 3 months, or if it is persistent, it is usually for more than 3 months. So if the headache is lasting for more than 3 months, it is a persistent headache, and it may be acute if it is lasting only for 3 months. Headache most often does not have classic features. The headache can look like migraine or tension type headache. It may be associated with lots of other features like dizziness, fatigue, cognitive impairment, anxiety, insomnia, and some of these patients go in this phenomenon of post-traumatic stress disorder. Who get post-traumatic headache? Typically, it is seen after mild TBI. 91% patient with mild traumatic brain injury would get it rather than moderate to severe. So it is more common with mild traumatic brain injury. And the risk factors are prior history of migraine, or prior history of other headaches, milder head trauma, and younger patient, younger than 60 years of age. These are the risk factors for post-traumatic headache. And the treatment of post-traumatic headache, we really don't know what is the best treatment. Usually patients are given tricyclic antidepressants or similar drugs. So treatment is symptomatic. There are no trials of treatment of post-traumatic headache. So I think I'll stop here. I'm already at 10:30. So carry home message about secondary headaches. Headache which starts after the age of 50, suspect giant cell arteritis. IIH always requires aggressive treatment initially. So maybe you can give weight loss, acetazolamide, high doses, then salt reduction, etc. Maybe some patient may require surgery. And always remember of mimics like Dural AV fistula, or maybe even chronic venous sinus thrombosis, etc. Spontaneous intracranial hypotension requires high degree of suspicion because the headache may not be orthostatic in all these patients. And if there are bilateral hygromas in a patient of headache, suspect SIH, it is not hygroma which is causing headache, but it is the effect of the headache. If the headache is associated with laughing and sneezing, look for Chiari malformation. If a patient has thunderclap headache, make sure that you image not just the brain, but also image the vessels by doing either a CT angio or MR angio, whatever you like. So thunderclap headache, always image the vessels. And if the headache is associated with cranial neuropathies, you are not just thinking of the skull meningitis, but also think of skull-based osteomyelitis as an important condition because it requires different treatment. I think I'll stop here. Thank you very much. So call sir, Dr. Subhash call. I think we can take the question after some time. I'll invite Dr. Subhash Kaul to talk. We all know Dr. Subhash Kaul. He is the course director and the main force behind this office neurology course. And he'll be talking about the last talk about the pains, and he'll be talking about the disorder of central pains, including post-stroke pain. Dr. Kaul, I think I need to unmute him. Is he there? I'll just try and call him. Sir, are you there?
Yes, I'm here. I'm just
so can you start your talk?
Usual formality. So, yeah. Mansi, are you there? Share.
What do you need, Subhash?
No, I'm share screen. Manasi, are you there?
Now, what do you need?
No, she had. Should I share from this, or she had told me to?
Yeah, see, now you start your PowerPoint. Your screen is being shared. Yes.
Yeah. That's okay. Okay. Sudhir, can you see the slides?
Yeah, it started. Go ahead.
Okay.
Go ahead, sir.
So yeah, the opportunity. So I'll be talking on post-stroke, primarily post-stroke pain, but also the other central pains because the mechanism is almost similar. Now, acute stroke management is a matter of few hours, and many times patient doesn't even see the interventionalist who does his job for 2 or 3 hours and then leaves. But post-stroke central pain is a matter of entire lifetime. He'll keep on coming to us again and again, and we are responsible for relieving his pain. And this is often true about all central pains, not only post-stroke pain. In fact, all pains have a central component. Even when it's a peripheral pain, it has a central component because pain is appreciated by the brain. And it's very important to know this diagram. This is the crux of all the pain pathway. Leave alone all the complicated diagrams. This is the crux, that the pain is basically, the pain, it's a loop actually. It starts from the peripheral organ, which can be a muscle. And then from here through the dorsal root ganglion, it enters the spinal cord with the substance P, and that is the transmitter. And then it goes up through the spinothalamic tract into the brain, into the thalamus. And from the thalamus, it's very important to know that from the thalamus, the pain pathway goes to the posterior parietal area, which is also called somatosensory cortex where it appreciates the pain. But pain appreciation alone is not important. It's also the reaction and the response to the pain. And that happens by this anterior arrow, which goes to the medial frontal lobe, to the cingulate gyrus, to the limbic system, right? And then there's also a descending pathway, which is very important, which starts from the periaqueductal gray matter. In fact, the descending pathway have got connections around the pituitary, a lot of brain areas, and they go down and then they give a feedback again at the dorsal root ganglia. You're all aware of the gate control theory. And this is all a chemical play. You know, in the ascending pathway, it's substance P, which is important. It's glutamate, which is very important as a pain transmitter. And in the descending pathway, it is noradrenaline, serotonin, and that is the whole basis of giving these, you know, SNRIs and SSRIs. So this loop is very important. So now, sometimes what happens is that generation of the pain is from the periphery, then it goes to the center. And sometimes in central pain, what happens, the generation itself is in the brain because of the lesion in the brain or in the spinal cord. But basically that whole thing happens around this loop. So it's important. And as I'll again reiterate, part of it, the appreciation finally depends on the anterior cingulate gyrus and the medial frontal lobe and the limbic system. Now, the lesions causing central pain are those which damage somatosensory pathways. They can be at the spinal, they can be at the brain stem, or they can be anywhere in the cerebral level, but they have to be in the somatosensory pathway. I mean, it has got a root. The root is spinothalamic tract to the thalamus, and from the thalamus to the parietal and the anterior part. If the lesion is not in this root, then they will not get central pain. But if they are in this root, they will get a central pain. And as I already said, peripheral pain also can get centralized if not treated early, because many times what happens, these circuits become self-reverberating, and even when the peripheral, you know, that on the central component of it continues. I'll come to it a bit later, but that's very interesting. But let us first see the causes of the central pain. The most important thing which we see in our OPD is post-stroke pain. Sometimes we see MS. Now that we are seeing it more, they come with pain. You know, Parkinson is a very important cause of central pain. We have to be aware of it, spinal cord injury, and then there are others. Now, initially, it used to be thought that central post-stroke pain is because of thalamic pain. Exotic name like Guerin-Roussy syndrome was also given to it, persistent paroxysmal intolerable pain. But over the course of, and then in the thalamus, you know, thalamus is a big organ. Thalamus has got so many areas. It has got a medial area, it has got a ventral area, it has got a lateral area. And out of them, the ventro-posterior thalamic region was thought to be maximally involved in the pain generation. You know, there are sometimes, we always see there are sometimes there are some thalamic strokes, they don't have pain. Whereas there are other thalamic syndromes, they have pain. This is because even within the thalamus, there's a somatization. But what has been realized after the MRI in the last 10 to 15 years is that it is not just thalamus, it can be in the subcortical area if they are falling within that, as I said, from that thalamocortical areas. They can be in the white matter anywhere. They can be even near the cortex, which cause this unpleasant central pain. So it is not just thalamus, but it's also thalamocortical radiation. It is the spinothalamic tract anywhere in the brain, which can cause these persistent, intolerable pains. And the reaction is because the impulses go to somatosensory, anterior cingulate, and limbic system. The emotional response is because of limbic system. And therefore, you know, many times patients tell us that when they are stressed or when they are tired or when they are emotionally upset, their pain also gets more, which is there. Their pain shows fluctuations, and a lot of times that fluctuations is associated with their mental state of mind, and there's a physiological basis to it because the underlying mechanism, underlying substrate is the same. Now, central post-stroke pain can be paroxysmal lancinating, but usually it is not. Usually it is not like trigeminal neuralgia, and in a small percentage of patients for some time, it can be paroxysmal and lancinating. But usually post-stroke pain is a nagging, persistent pain. I would say it's a persistent part of your life. It never goes. And you must be seeing in your OPD that patient of lacune, he's happy, he's independent, he's back to his work, but he tells you, doctor, I'm still having some pain here. Well, it reduces sometimes. Sometimes there are fluctuations, but it's there. It's personal. It is part of their life. And this we have to realize. Now, what is the timing and character of the central post-stroke pain? The interesting thing is that it can develop in the first week after stroke, or it can develop 1 or 2 years after stroke. This is a new knowledge which we should know, that it can come later also, as late as 1 year. It can be constant, it can be intermittent, it can be burning, it can be scalding, and the patients will give you all kinds of expression. You know, many times we get irritated when we ask the patient, do you get this kind of burning? He will say, sometimes. Do you get this kind of pulling? He'll say, yes, it happens, but sometimes. And we think he's functional, but actually he's not functional. Actually, this is the character, that there are fluctuations in the intensity of the sensory phenomenon. It may also be associated with hyperalgesia and allodynia. So what is the location of the central post-stroke pain? And again, there are some nice experiments which have been done, nice observations which have been done, which throw light on the location of post-stroke pain. The pain may involve entire one side of the body. That is the common thing, that is a stereotype. But the pain may involve only face. The pain may involve only trunk. The pain may involve only hand. So this is a very important thing. And this distribution also can keep on changing. Initially, the patient may be having pain in entire one side. After some time, he'll tell you, pain in my leg is gone, but now I have persistent pain in the face. All this can happen. So it can involve only a limb, part of limb, or the face, and it can change. So therefore, in fact, in my practice, many times initially I used to think, if a patient would say, I'm having knee pain, I would think he's having osteoarthritis, but on examination, there used to be nothing. Even x-rays would not show significant disease, and actually he was having a central pain. So central pain can present just like a knee joint pain or an ankle pain, but we should not miss the real osteoarthritis or the real ankle pain or the real trigeminal neuralgia. So all these patients must undergo musculoskeletal and psychological evaluation, but we must remember at the back of our mind that central pain can be focal, can be contralateral. Now, many times these central pains can be accompanied by abnormal sympathetic activity, edema, hypohidrosis, trophic skin changes in color. It is unusual, but sometimes it can happen. And I want to bring your attention to complex regional pain syndromes, where you see that patients having a severe pain in the shoulder and severe pain in the hand. The question is it a central pain or is it a peripheral pain? Well, it seems that there's a contribution of both things in this. In fact, it is started because of the immobilization. Immobilization is a trigger to the central, to the complex regional pain syndrome, but it is thought that there may also be some central contribution to it because of the sympathetic. It's both. It is peripheral as well as central. The term they use is movement allodynia, because with movement, if they do movement, they get pain. They don't move it at all, and that triggers this pain. But it's not a pure central pain. It is kind of a peripheral pain, but with a contribution of central component. Now, what is the mechanism of central post-stroke pain? How does it happen? Well, it is shown that through very exquisite neurophysiological experiments and all, you will see a lot of literature, that there are spontaneous discharges in the thalami and cortical neurons that have lost part of their normal feedback. So spontaneously, once there's a thalamic damage, it just keeps on discharging. The question is it epileptiform? Well, there have been epileptiform discharges documented at scene. In fact, if you do EEG of some of these patients, you will find that there are sometimes epileptic discharges. I don't know if Dr. Varalakshmi is right now seeing or not. Varalakshmi used to argue with me many times. She is one of my colleagues, that, sir, many of these patients actually are having seizures, and sometimes she would show in the EEG that there were some discharges. Well, all of them are not because of epileptic or epileptiform discharges, but that is one of the mechanisms. But many of them are because of abnormal ectopic electrical signals, which are kind of epileptiform, if not epileptic. And you know, therefore, we give them even anti-epileptic drugs as part of their treatment. And functional MRI and diffusion tensor imaging have shown that the damage of these thalamoparietal fibers, which are normally there, they release the activity of the anterior cingulate and posterior parietal regions. Because normally it's a loop, as I said, there's a feedback and a counter feedback. Because of this, all pain is controlled. But when there is a damage in it, there's a release of the feedback and the patients continue to have these abnormal sensations. Another mechanism which has been proposed is the loss of opioid receptor availability. We are all aware that there are opioid receptors which are predominantly in the periaqueductal gray matter, but they are found everywhere in the brain. They are not only in the periaqueductal, and in these patients it is seen that either they are damaged or there is a down regulation of these opioid receptors, and they don't respond to the normal endorphins which are produced in our body. PET studies have revealed a striking loss of their availability in contralateral thalamus, anterior posterior cingulate cortex, insula, and prefrontal cortex. And this may be secondary to down regulation of these receptors. Down regulation means they may actually not be damaged, but they may not be effective enough, resulting in the reduction of effectiveness of endogenous opioid-mediated analgesic mechanisms. So after stroke, I come to multiple sclerosis. Last time Rahul talked very nicely about it, but basically I tell you, it is same. It is common. In fact, in MS patients, if you talk to them, some of them are very well controlled, but some of them keep on complaining of this nagging pain. And sometimes we have to analyze whether it is really a new attack which is coming on, or it is part of the baseline pain because of the damage. And this is because of the damage to the myelinated fibers, to the myelin, removal of the modulation of the afferent A delta C fibers, and interruption of the inhibitory impulses from the brain. And it's common. We have to be aware of it. In all patients of trigeminal neuralgia or any other neuralgia, we have to always rule out multiple sclerosis. Parkinson's disease is very interesting. I think most of you who have seen Parkinson's disease must have seen that in the initial part of Parkinson's disease, they may only complain of leg pain, for which you have no explanation. They may only complain of even generalized body pain. And pain is one of the earliest manifestations of Parkinson's disease, early Parkinson's disease. We have to be aware of it. And I'm sure at least the senior neurologists have seen this, they know about it. And even after you diagnose Parkinson's disease, they will be complaining of pain in their toes, on their both sides. And it has been found that basal ganglia may be involved in providing a gating mechanism for modulating nociceptive information, including sensory discriminative, cognitive, and affective aspects of noxious stimulation to higher centers. You see, this pain is very interesting. These regulatory mechanisms inside the brain, the descending noradrenaline pathway, are very important. If they were not there, then even wearing our clothes would cause us pain. Even wearing our shoes would cause us pain. Because every time we do some new sensory experience on our body, the body knows that there is something new, which is when we wear a new shoe. But then the descending pathways tell the brain that it's okay, and we get used to it. But if something gets wrong with it, then all the time we'll have this unpleasant sensation going on. And I think this thing what happens in the Parkinson's disease patients. Spinal cord injury also, the same thing I have to say, that it can begin immediately, but it can begin weeks or months after injury. All of us see these patients when they go to neurosurgeons, but when neurosurgeons are not able to deal with their pain, they just send them to us and we have to manage them. But in spinal cord injury patients, particularly, they can develop also eventual nerve trap entrapment or syringomyelia, and we have to make sure that we are not missing them when the spinal cord injury patients complain of pain later on. And pain in these patients is because of nociceptive primary afferent neuron displaying persistent hyperexcitability in their peripheral branches, even after the trauma has healed, but that damage is there permanent, and it is permanently causing that sparking because of hyperexcitability and causing, the term is central sensitization. The centers become hypersensitive to any smallest stimuli. Central sensitization is a big topic these days. It is the basis of chronic pain, and you will get a lot of articles on it. And the neurochemical involved here is glutamate, pro-inflammatory cytokines, ATP, reactive oxygen species. It's called gliopathy. There's a gliopathy after these head injuries and after their spinal cord injuries, which are responsible for the chronic pain. Now, another very exciting and interesting thing is pain in dementias. There is a lot of literature which have shown that chronic pain can lead to dementia. Chronic pain, not as a cause, but not as a manifestation, but as a cause of dementia. It has been found that chronic depression, chronic pain is one of the pathogenic mechanisms of dementia. But then that's a different topic. But then there are also papers which show that because of the brain damage in these dementias, they may also have pain. In fact, many of us know that dementia patients are constantly moaning. They cannot complain of pain. They have lost their articulation, but they are moaning. Many of the Alzheimer patients, attendants come to us and say, sir, our patient is constantly moaning. We ask her, where is your pain? She's not able to say, but she's constantly moaning. And then we have to give them some drugs to suppress that. So this is a new area, central pain in chronic dementia. It is not as much, proved as yet, but it's on the frontier of the new research, central pain in chronic dementia. Now, another central pain, which I'll make a brief reference, it's also a separate area in itself, is fibromyalgia. Fibromyalgias are pains without an obvious cause, pains without any neurodeficit. All investigations are normal. They may be having depression or anxiety, but that is not the cause of it. Nobody knows what is the cause of fibromyalgia. And how you diagnose it is that as opposed to post-stroke pain or as opposed to post-MS pain, they have pain all over the body. They have pain in the neck, they have pain in the chest, they have pain in the knee joints, they have pain in the elbows. They're all called trigger points, and they have as many as 32 to 48 to 138 points all over. There are a lot of criteria about counting these points, but the basic thing is that they have these pain points all over the body. Why they happen, nobody knows. But what they have found on basis of these studies is that in their patients, there is a lower threshold of pain perception. So fibromyalgia is a central disease. The patient complains of pain all over the body, but the problem is in the brain. And what brain does is that there's a lower threshold of experiencing the pain. Everything causes pain to them. Even when there is no stimulus, they get pain. There is spontaneous pain. Why it happens, nobody knows. But it's important to make this diagnosis, because rather than dumping them with kilos of vitamin D and causing toxicity, it is better to make a diagnosis of fibromyalgia and treat them with various modalities, and you will get some success. And another clue for fibromyalgia is that it does not come with pain alone. It has associated migraine, it has sleep disturbances, balance problems, dizziness, ringing in ears, ear pain. Memory problems are very common in fibromyalgia, sweating. So we have to keep this also in our brain. It is not purely a focal central pain, it is more diffuse, yet the etiology is in the brain. Now, this is what we should realize, is that peripheral pain over the course of time, if not treated, can also get centralized by sensory amplification. So basically what it means is that circuit becomes self-perpetuating. So therefore, before it does that, we should treat chronic arthritis patients, chronic neuropathy patients, chronic soft tissue injury people. They have a central component to their pain. So it is very important that we should treat it. And the best model of it to prove this concept that peripheral pain can become central is the phenomena of phantom limb. Phantom limb is that even when you cut an amputated limb, the patient continues to have pain of that limb, even though the limb is not there, but in his brain, there is a memory of that pain. And even when you have cut the limb, that memory still persists there, that circuit still persists there, and the patient continues to have pain due to interruption of sensory nerve impulses by destroying or injuring the sensory nerve fiber after amputation or deafferentation. And the incidence of phantom pain is 60%. Stump pain is seen in more than half the patients with these patients. And I have also seen phantom limb pain. And now it has been seen that phantom limb pain can come not only after amputation of limb, but after amputation of anything. There's a phantom breast, there's a phantom eye after. And I have seen these patients. I have not seen phantom breast pain, but I have seen it's common post-enucleation phantom eye pain. So we have to be aware of this. Awareness is very important, because if we are aware, then we can manage it effectively. And why this happens? It has been proposed that there's a changes in the neural processing which occur in the dorsal root ganglion and dorsal horn of the spinal cord, where second order neurons respond to input from mechanosensitive fibers that carry non-noxious stimuli. And even after the peripheral organ is gone, the dorsal root ganglion is still there. So it keeps on firing the stimuli. And long-lasting input from limb and cortical pain memory that enhance excitability and reorganization of the somatosensory zone correlate to area of the pain. Now, another thing as a clinician, see, we are not physiologists doing experiments in the lab. We deal with the real patients. And real patients don't have one disease. They have many diseases. They are a combination of diseases. So just because a patient is having a central pain, he can have a cervical radiculopathy also. He can have a carpal tunnel syndrome also. He can have a lumbar disc prolapse also. He can have osteoarthritis also. Most likely he will have, because he's in that age group. He will have lumbar spondylosis. He may have, so therefore, as a clinician, we have to make a diagnosis and then integrate into one model and see what all diseases he can have. This is very important so that we don't miss the diseases and not give him the appropriate treatment. So the treatment of central pain is difficult. It is frustrating, but not impossible. If you have patience, you can do it. Guidelines are given in various societies, but I'll just summarize it. I'll just summarize it for the busy clinician. The first line medications are tricyclic antidepressants. It's amazing that even now in 2020, the first undisputed treatment is amitriptyline. There is nothing which can beat it, even though they are saying in diabetic neuropathy, you can give duloxetine and all. But for central pain, amitriptyline stands far above others, and we have to use it and use it in maximum dose. I'll come to that. The second is gabapentin, and as you see, there are mechanisms. Gabapentin is basically anticonvulsant. Pregabalin is the anticonvulsant. So these actually act on the ectopic discharges, and tricyclic antidepressant act on the descending pathway where they increase the levels of the norepinephrine. So these are mechanism-based therapies. Topical lidocaine has also been used. I have not used it much, but it is given. There's a lot of praise for it as a first-line medication. Now, after these second-line medications are opioid analgesics, you know, tramadol and Ultracet and all that we give, but they are second line, not the first line. And the third line medications are lamotrigine. You can give any anti-epileptic, but most of the trials and research has been done on lamotrigine. But we should remember, when we use lamotrigine, it has to be used in the same way as we use in epilepsy. You have to start with very small doses, half tablet of 25 mg, then 25 mg, slowly, slowly. But there are some recalcitrant cases who don't respond to other. Their lamotrigine may help. Some people have used other anticonvulsants also, like topiramate and all, but I'm telling you where there is a maximum recommendation. That's for lamotrigine compared to others. And you can use other antidepressants like escitalopram and all, but first we have to try tricyclic antidepressant like amitriptyline. And of course, some people have responded to mexiletine and topical capsaicin and all. Those are individual responses. So each patient may respond differently to different medications. Sometimes we may have to give more than one medication to any person. Okay. Now, another thing is that amitriptyline can be taken up to 75 milligram every night. Many of us, after 10 milligrams only, our patients become drowsy, or we become little, non-confident, but we should give full benefit slowly, slowly. The recommendations are you have to give up to 75 milligram of amitriptyline. Gabapentin should be tried up to 1200 milligram, pregabalin up to 900 milligram. It's easy to say. You will say that our patients become drowsy and all. They do become drowsy. But if you do gradually, some of your patients will be able to tolerate, not all of them, but some of them will be able to tolerate. So you should know that you are allowed to use this much, but also monitor the patient slowly. And many times you have to combine amitriptyline and gabapentin. And lamotrigine can be tried in some patients. And carbamazepine works well in some patients. So you have to individually, one by one, do by hit and trial method, but not ever give up in these central pain patients. They are difficult, but this is the way to go. And now this is something which is a little provocative, that there is some literature where people have used atypical antipsychotics, you know, like clozapine, like quetiapine, for a short duration to break that cycle. As a neurologist, I would not encourage to use it, but I have seen some fantastic clinicians using it for small time. And I have seen that there are some literature that in some patients for a limited period of time, particularly central sensitization, fibromyalgia, where people have given antipsychotics, but it's a very, very responsible decision. We cannot loosely talk or that this can be given for a small, particularly a combination of small atypical antipsychotics with a heavy dose of amitriptyline. Now, cognitive behavioral therapy is extremely important. This is all neurologists should know about it. It is not a vague psychiatric concept. If today there is evidence for any pain treatment, it is for cognitive behavioral therapy. Now, cognitive behavioral therapy, in this we make the patient understand the mechanism of his pain, local and central. We treat him as a student and we make him understand that why does he have this pain, and we make him understand why the pain will not completely go. We have to make him understand that some pain may remain. If there is a tolerable pain, if there's a 50% pain, 40%, which he can tolerate, it is okay. It's okay. It is not going to increase. So you have to actually, like a psychiatrist, we have to convince the patient and we have to tell him that this pain is also temporary. It will go away eventually in the end, but before that it can be definitely reduced. Now, interestingly, cognitive behavioral therapy has been proven effective by randomized double-blind trials, much more than our drugs. But what I would suggest is that we should not send it to a psychologist or somebody and ask him to do CBT. We should do it ourselves. And there are a lot of softwares, a lot of books available on the internet. And we don't have to do that long half-an-hour cognitive behavioral therapy. As a neurologist, I think we can be the best speech specialist, best swallowing specialist, best physiotherapist. We can do everything. And this also we can do in a limited time. I would say in 5 to 10 minutes, if we spend with the patient, it will be more effective than if you send it to a psychologist whom you don't even know. And the patient also is more convinced by us. But it's very important, and you can learn it. Internet, a lot of resources are there. Cognitive behavioral therapy for patients of chronic pain. Now, other methods of pain relief are transcutaneous electrical nerve stimulation, transmagnetic stimulation, acupuncture, acupressure, even deep brain stimulation has been done. I had one patient once, one politician who wanted deep brain stimulation. I talked to Dr. Rupam about it. And then there are aggressive, like sympathetic blockade. These days we have got pain specialists. They do cordotomy, dorsal root entry zone lesions, thalamotomy, cortical and subcortical ablation. But having said that, all these methods would be applicable probably to 1 to 2% of chronic pain, not 3%. In 95% of the patients, you will not need this, and you will have to do the conservative methods, which I showed you. Now, there is also, I want to show you one clip about the phantom pain. And in fact, for the phantom pain, there is a lot of work is done by our own Indian neurologist, Dr. Ramachandran, who is based in US and who keeps on coming to India. He did a mirror therapy. In mirror therapy, what happens is that the patient looks into a mirror where he looks into the normal hand, and his brain, because there's an image of the normal hand in the mirror, the brain confuses the image as the lost hand, as the cut hand. And it has been found that, in fact, that causes some improvement in these patients. It has not come validated, mirror therapy has not come as yet a validated treatment, but many of the rehab people are already using it. I'll just run it, I'll see if it runs. Please, this is one of the last slides, and after that.
James Peacock has suffered excruciating pain since he lost his hand 6 years ago.
A few days after I'd woke up, it might have been a week to 8 or 9 days, something like that, before the pain really started getting bad, to where it was like your hand is just crunched up real tight and stuff, or balled up, and you can't move it. To unclench, it's just, you can't. You've tried in your mind.
This raises a perplexing clinical problem. How do you treat pain in a body part that's missing? James tried everything, from painkillers to hypnotism, but nothing worked.
Until I found out about the mirror box.
It was then that he came to see Ramachandran.
And one answer might be that the brain is sending signals to the arm and trying to clench it, but in you and me, there's messages going back from the muscles of the hand telling you you're clenching too much or too fast, and this damps the command signals, so you can slow down. But the patient has no feedback because he doesn't have an arm. So the brain says, send even more signals, okay? And this goes on, and you get into a sort of positive feedback loop. So I said, well, if you give him some other source of feedback, such as visual feedback, maybe that'll trick the brain into thinking that the hand is clenching or unclenching, and maybe you can interrupt this loop. So I said, well, why don't we put a mirror there and have James look inside the mirror? It's as though you have visually resurrected the phantom limb. And of course the patient knows it's an illusion, but it's very, very compelling.
Right now, as you look in there and you move your hand, your phantom does the same thing as your left hand is doing. First time I got in here and I've done this, and it was just like, it relieved the phantom pain, unclenched it. You know, it was just, oh, so intriguing, you know. Sometimes it's hard to explain how you felt, you know.
Ramachandran believes the mirror box needs to be evaluated with many patients before he can be sure that it really works. But its undeniable success in uncramping James's phantom hand suggests that even pain can be a construct of the mind.
Okay, so what I would say, don't give up on these patients. Take pain patients as a challenge, right? You know, I once asked an Australian doctor, I said, how do you treat these chronics? But he takes them as a challenge. And we send all these patients to him. Take it as a passion. You need to have tremendous patience when you see with these patients. This I'm telling you also on my own experience. You listen, analyze, and briefly explain to patient that why he's having that problem. Patient will insist on his own theory of pain, because patients are also these days, you know, he will tell you, no, you are wrong. It is coming, it's a nerve pain. It is coming from a nerve. But don't get irritated by that. Avoid hostility with patient. As neurologists, no, sometimes we develop hostility with the patient. We don't want him to come to our clinic next time. But we have to avoid that. We have to have vast reservoirs of patients, because we are neurologists. We are different. We are best. And give cognitive behavioral therapy in your own way, rather than referring him to some psychologist. I hope no psychologist is hearing at this time. They'll hate me for this. And try pharmacotherapy based on cause. And you know, you have to do various permutations and combinations. In some person, only gabapentin will work. In some person, gabapentin plus amitriptyline will work. In some person, you may have to add a little bit of lamotrigine. There is no hard and fast rule. These are the 5 masalas which you have, and you have to give them in various combinations. In fact, your OPD is your kitchen, and you have to make a dish, and each person's taste is different. And depending on that, you will give a recipe to them. So pain is personal. Every patient's pain is personal. It is not visible. It's personal. He feels it. But so is its treatment. It's also personal. And since the evolution of this world, human beings have felt pain. And when they feel the pain, we have to feel their pain. We have to relieve their pain. There is no bigger joy than that. Thank you very much.
Thank you, sir. Indeed a good lecture, very good lecture. So do we take few questions? Do we have some time? We are at 11:10, so maybe we take a couple of questions. Dr. Kaul?
Yeah, I'm fine. You can take the questions. I'm just trying to get my screen.
So maybe, yeah, there are some questions which are asked to you. Maybe I'll start with the question which have been asked to you. There is a question which says that, can we use lacosamide for chronic pain management, or any role of carbamazepine for chronic pain management?
Or any role of?
Carbamazepine or alpha blockers for chronic pain management. So they're asking about these drugs.
Yeah. Yes, absolutely. You see, I only told you about the trials. Trials have shown amitriptyline, so it is recommended to use amitriptyline in maximum dose. And trials have shown gabapentin, and maximum trials are done on lamotrigine. But obviously, if your lamotrigine also fails, you can try lacosamide. Definitely, you can try any anticonvulsants. And if there are any other medicines, but there has to be some evidence, at least case reports. If they are, you can definitely go ahead, even with your alpha blockers also, yeah.
Okay, and there's one question which says that, how can the edema or the swelling of the paralyzed limb which comes after stroke, which may last for a long period, maybe months?
Yeah, that is true. I think that is the complex regional pain syndrome. It can last for a lot of time, and it is basically because of the autonomic changes, because of immobilization. Usually happens in shoulder, but it can happen in knee joint, it can happen in foot. And you have to do gentle physiotherapy. You have to give them anti-edema measures. You have to give them non-steroidal for reducing the edema. And sometimes you may even have to take the help of pain specialists, and you may have to do sympathectomy and all also, sometimes in these patients. But mostly they will respond to physiotherapy and medication.
Yeah. There are some questions which have been asked about IH. There is one question which says that, why do we get tinnitus in IH? So the answer for this is, of course, the tinnitus comes basically because there is transmitted systolic pulsation of the CSF, which can go through the venous sinuses, and then it can lead to the tinnitus. There was one question about IIH management in first trimester of pregnancy. So obviously, in first trimester of pregnancy, maybe weight loss or maybe giving drugs like acetazolamide may be a problem in first trimester of pregnancy. So I believe the best treatment option for the first trimester of pregnancy will be doing a lumbar puncture, maybe repeat it later if needed. There's one question which says that how do we manage acetazolamide induced tingling and the pin sensation in the foot? How can you do that? So I really don't have any answer for this. Usually I would tell my patients that you are going to get some tingling, maybe not just limbs, but also perioral area, and you have to bear with it. Any answer for this, Dr. Call, for you from your side?
No, you see, if we again, we have to do cognitive behavioral therapy. We have to. I usually tell them that, you see, if you get tingling of your limbs, that means the drug is working. It's a good thing. I would be worried if you did not get tingling. If you are getting tingling, that means it's working in the brain. But in spite of that, there are some people who will find it intolerable. So one step is to reduce the dose, and then I add diuretics, Rahul, in those patients. I may add furosemide or Ditor and all in those patients.
Correct. Then there's one question which says that BIH is not so benign disease. So that's right. Now the name has been changed from BIH to IH. We use this term, no more BIH. And then MRV in patient of BIH, we get this stenosis. So whether it's an incidental finding or there is a definite correlation, we know that there was a big controversy which came up maybe 10 years back, Dr. Call, where people said that stenting of the intracranial venous sinuses may be a good option for treatment. There were people who demonstrated there was trans stenosis difference, pressure difference, and there are people who stenting bilateral. And then it was also known that typically the stenosis is seen where there is a loop, and it was always thought that it may be because of raised pressure that they are getting pressed. So there was a question whether it's a cause or effect of the stenosis which is caused because of intracranial pressure, or whether vice versa. And then I think 10 years back there were a large number of people who were stented there, but now we know that the numbers of patients who have been stented are much lesser and lesser. And actually in certain patients we had seen that if you treat them, the stenosis disappears because it may be just an effect of the pressure. So there's still complex relation between these two things, stenosis as well as raised intracranial pressure. Do you want to say anything?
I completely echo what you said. About 10 years back in All India Institute, actually, they first noted that there are stenosis, and they had a series of stents also. But over the course of time, it was found that this is the effect rather than the cause of the BIH. But still, this theory is not totally out. There may be small percentage, 1% of patients or so who may be having. So if your patient of BIH is not responding, even after 6 months of treatment, and you find that these stenosis are there which have not gone, then you may consider stenting, but that will be a very small percentage.
Okay. And then there are questions of persistent post-traumatic pain which comes after a mild traumatic brain injury. Can it be central post-stroke, central pain, or is there some additional neuropathogenesis underlying it? Of course, we know that there is this phenomenon which is called as post-traumatic stress disorder, and then it then merges with the headache, with the central pain syndrome and the somatization syndrome. Everything merges together. So probably we'll have to take cognitive behavioral therapists, maybe psychologist, or we have to become psychologists, as Dr. Call said, and then of course use the drug. So it's probably would fall in this gray zone area where it is headache plus the central pain syndrome as well as the somatization. It may fall in one of this.
Correct. I agree.
Yeah, and then there are a few more questions. Whether you choose between TP shunt and optic nerve fenestration. This is another question about IH. Now the issue is that optic nerve fenestration surgery is not being done very often. It is done by selective ophthalmologists. Of course, it's a good surgery to relieve papilloedema, but it is not going to relieve the intracranial pressure per se. So maybe to relieve intracranial pressure, probably shunting may be a good procedure. Of course, it depends on your local choice. There is no data. There is no trial to differentiate whether one surgery is better or other, and people have tried one or other. So depending upon what you are comfortable with, what your center is comfortable with, and what your surgeon is comfortable, you can decide what to do. I think we stop here. There are one more question. There is there in the role of ropinirole in fibromyalgia? Someone has asked you.
No, but ropinirole has a definite role in the restless lung syndrome, but not in fibromyalgia. You may try it, but otherwise it has been studied in the restless leg syndrome.
Okay. So I think we'll stop here because we are already over timing. There are certain questions which are to be unanswered. So maybe me as well as Dr. Kaul will try and answer these questions in the windows if possible. So thank you very much for attending this office webinar. It is going indeed moving on well. We have